standing out in the rain for an hour or so. So there you go. I apologise. You're not on here to look at me. I know you're on here because you want to hear the incredible stories that I get to share with Tink. I'm just giving us a little bit of time for people to hear that we're online. Hi Brooke, lovely to see you. Hi Isabel, thanks. And hi Marianne, lovely. Wow, everyone's jumped on quickly this morning. It's fantastic. Hope everyone was okay in the storm last night. I'm not sure. I ended up with 2 dogs hiding in under beds, so I'm sure everybody else probably had similar experiences. And yeah, sorry I'm a little bit late on today. As I said, I've just spent an hour out in the rain trying to meet people and talk to people about what we are trying to do with this campaign. Oh, Sydney just saw the electric billboard truck in Northbridge. Go. It's fantastic. Well, actually, that's been a really interesting exercise, Sydney, because we did take it on board, but it's been a really important opportunity for us to spread awareness around the importance of electric vehicles, actually. So we took the step of, we tried to get an electric truck, but of course they aren't readily available in Australia at the moment. So we've used it, we've offset the vehicle completely, and yeah, it's been a great opportunity for us to have a conversation with people about trying to get more electric vehicles into the country faster. So anyway, so thanks for joining everyone. Hi James, hi Zach, hi Jason. I loved the picture of your buxus. Buxus that you've got there, so beautifully shaped. Okay guys, I think we have a nice starting lineup, and I'm really excited to, as always, as you guys know, Tea with Tink for me is a moment where I just get to stop and listen to somebody who has incredible expertise in an area that we may not always get to hear about. And this morning I'm really excited to have Professor Robert Booy is going to be joining me, and I can see that he is ready to come in. So I'm going to let Robert in, and then we'll talk a little bit about his background, Professor Booy's background, what's important to him, and what he would like to see us be doing differently as it comes to at our federal government level. So hold the line, please, guys. Here he comes. There. Hi, Professor Booy. How are you?
Good. My name's Robert, so you can call me Robert.
Well, you know what? It's really interesting, Robert. So one of my first jobs out of university was at a hospital. I worked at Southeastern Sydney Area Health Service, and I learnt working in that environment that it's best to assume that it's always professor or doctor, and then when invited to use somebody's first name, go for it. So thank you. It's lovely to meet you, Robert. Thank you for having a cup of tea with me this morning. How are you?
I'm well, thanks. Came to your campaign on Sunday morning. It was brilliant there. There were at least 1,000 people there, so a very good sign.
It was incredible, wasn't it? I actually, I've been at this now for about 5 months, I guess, and the thing I love about it is actually just talking to people and understanding what's important to them. And I confess, when I walked out of that the clubhouse on Sunday and just saw this sea of pink, it was literally breathtaking. It was very, very humbling. So it was a great day. I agree. The vibe was fantastic, wasn't it? And Baxter, his song for us to get us to Canberra, I thought is an absolute winner. It's just like a earworm. It just sticks there, doesn't it?
Got to get it on the radio. No, it's a I think everyone was encouraged.
Yeah, I agree. Well, thank you for being there. I really appreciate your support. Now, I'm really looking forward to this chat today, Robert. So just to give everyone a little bit of background on you, so I'll read your written CV if you don't mind, and then we can.
As long as it's a short one.
3 pages. Yeah, is that like? No.
3 lines.
No. It actually is 3 lines. So just for everyone joining us this morning, so Robert, it is Professor Robert Booy, and he is an infectious disease and vaccination expert of 35 years standing. So he's a University of Queensland medical graduate from 1984, 1990 to 99, he's MD, and his MD was done in Oxford. He's the founder of the Oxford Vaccine Group, 1994, paediatrician, professor at the University of London from 1999 to 2005, and a former director of the NCIRS from 2005 to 8. He's also the former chair of the Immunization Coalition from 2018 to 2020. And when I put the question to Robert, what is important to you, he came back with a very distinct and short public health. So with that, and when I asked him what we could do, he said a great deal. So we are going to be talking about all things public health today and the experience our communities had, recently with COVID, and importantly, where we need to be going forward. So Robert, it's over to you now. Tell me, why is public health so important to you?
Public health is a means by which to empower people to do their jobs, to be well, to have health. My qualification as a physician for children, but I've been doing research on the elderly. I've been very interested, especially in nursing homes, where I feel the greatest gap exists by way of looking after the health of our older Australians. May seem funny for a pediatrician to do that, but I've always been who's collaborated widely and with other experts. So I'm currently working on a project with half a dozen different specialties: geriatrics, virology, nursing homes, GP, epidemiologists, industry. And what we're trying to do is, what are these outbreaks that are killing so many people in nursing homes? Well, we know that it's COVID, and we know it's also influenza. And there is a means in which you can do tremendous applied research. So really, the key word is application research. We've had a dozen or 20 inquiries to the health care setting, residential facility. And the problem is not getting another inquiry, what are they called? Royal Commission. Yeah. The problem is applying what we've learned already. And the thing I can do at the moment, and I'm working with both industry and public health in New South Wales, as well as in Queensland, is to set up a system where we can very quickly identify an outbreak, a problem, the exact cause of it, to immediate control measures. So that's simple things like we all know, quarantine, infection control, hand washing, gowns, gloves, but also there are specific treatments for flu that give someone so they get better quicker and they don't, and specific treatments for COVID. So I think by working together we can achieve something. At the moment, there are clinics being run from hospitals in Sydney for people at high, but they see people who in their 60s who can get people in nursing homes, they need our help. What I wanted to say very clearly, I'm a bit roundabout at the moment, but what I wanted to say that was we could do so much better. And we all hear what these simple solutions are. We need more. They need better training. We attract who can do the job. So many shifts in a nursing home have just one registered nurse and the rest are care assistants with minimal training. So were we to invest more in people for professional care, but also personal care, I have so many examples, including nurses who've worked with me in research, who haven't been able to get to see their elderly father, whether it was Adelaide or Brisbane or Sydney. And if the approach matters for the elderly from a professional point of view, better care, more care, better training, better pay, better quality, but also from a personal level, getting people who are relatives full training certificates so in, solitary confinement, what prison, not what nursing homes should do. Solitary confinement has been wrong, and people have been dying and of giving up hope. And if we combine a professional approach with a personal approach, where close relatives can be given minimal training so that they can be caring for the person instead of having them looked after by from the as whole simplistic approach is just said, for goodness sake, we can do so much. So,
I love that idea. But what a great idea, Robert. And such a simple idea. I mean, I think that it's been heartbreaking to watch what's happened with COVID through our aged care facilities. And to your point, the whole concept that they've actually turned into lockdown zones where families haven't been able to get into. I mean, I've had multiple friends that have had elderly relatives that they couldn't get in to see. And it's not good for health. It's not good for anybody's health. So I love that idea. So simple solution. Let's train up some immediate family members so that, they can go in and help in a system that's under pressure.
Yeah. It's sort of staring you in the face that we can do so much better, so much more passionate approaches, really looking after people we care about them, and that's your closest relative. I remember walking in Western Australia at a conference over 15 years ago and thinking about the problem and thinking, what about getting kids in and the visit nursing homes? And then maybe ran the story, started running the story 12 months ago. So that's perhaps a harder thing. Actually, a lot of people have talked about care for young children close by to nursing homes. There is potentially more interaction. They're very old. And we'll see series of programs on the ABC recently been repeated. But it's if care and compassion was able to be better introduced, better innovation with getting young people, what we can do here, how interact better. Anyway, there are a few of my ideas. As a paediatrician and as an epidemiologist, epidemiology you've heard a lot of, but it's a simple science, public, and it's all about determining what causes ill health and what can improve, and in simplest terms. So where practical, I happen to be a clinician. I worked in hospitals for a long time and until a few years ago. I think where clinical care needs public health, there's a lot of things that are old people are falling between two.
And actually, because I want to pick up on what you've just said there, that between clinical care and public health, there is a lot of things we can be doing. And, but the sad thing is at the moment that our elderly population is falling between that gap. And the reason I just want to pick up on that is it would be 2 weeks ago now, I was talking to somebody else from the infectious diseases space, and she shared with me the fact that up until recently, so we're talking the last 3 to 6 years, it was actually very common as a public health practice to do a review of what was happening as issues emerged, and with the intention being you do an immediate interim review, work out what's working, what's not working, to then potentially change your behaviour going forward. And her kind of observation to me was that she lamented the fact that our federal government hadn't played a greater role across our country in encouraging these interim reviews to be happening continuously and consistently so we could be improving. Her observation that it was more that we just keep going back and making the same mistakes, it's lockdown, shutdown, that's our only course. And I just want to touch on, you yourself just said, we don't need another Royal Commission. We're having Royal Commission after Royal Commission, and I think there is a place for those. But can you talk to me a little bit about your opinions on the importance of learning in the moment, and then having the capacity within the system to respond to what you're seeing, and the potential of that to actually have literally saved lives in terms of what we've seen in the last 12 months?
It doesn't have to be complicated. As I've said already, we can do fancy ECR, and we actually have a proposal to do it in nursing home surveillance and do immediate by way of treatment management. But people just sunshine, people interaction. With their relatives. When people talk about old people getting sick, they don't get sick because their relatives are visiting them, because on average they get less. The reason they get sick is because staff are going from room to room and spreading infection, sadly, even if they are washing their hands and wearing a mask. So to understand the situation that we're in, that they're mostly interacting with people who are not relevant, and they're not getting, it's too hard to get them out of bed. Sometimes two people to get them out of bed. So we need more staff. We need staff to get them into a chair or get them walking with a frame and get them sunshine. And they get an hour of sunshine every day. And I'm not answering your question very well, but let me reflect on a marvellous thing I heard from France over a year ago. I usually do about 3 hours a day just on COVID, and I read France had a nursing home where the staff lived in for a few weeks over an outbreak. So rather than bring you in, staff slept in there. They, over the course of 2 or 3 weeks, they made it to the survival and the quality of care of their people, their elderly people. So there's so much simple innovation, so many simple things that that we could do, or if we're doing them, we could do better. We visited quite a few nursing homes as part of the research and talked to the staff. The staff are, but so often they're people who have, they're culturally and linguistically diverse because they're not paid well. So down simplistic things like get more. Can you repeat part of it? I haven't.
No. No, you're doing a great job. I mean, I'm just going to move rooms because for some reason I think my internet might be a bit scratchy in here. So don't mind me while I walk through my office. I'm going to sit up in the front area. No, my question was just, I mean, and I think you've kind of addressed it. When you are in a situation where you have the opportunity to learn as you go and observe what's going on, how do you make sure that the system is set to the point that it can respond really quickly? And what I just heard you say was that actually that's not hard, but what you need is a willingness and a capacity within the system to kind of think ahead. What is the more compassionate approach here? How could we be doing this better?
Another lovely idea I've just heard that my wife shared with me, who's on your team, her name is Anna Booy, and I also heard this through the media recently too, smaller settings, which are more personal, more like a family, more like an extended family, more like a small community. So smaller settings is something we could aim for. When I started doing research in nursing homes, it was about 17 years ago. We were working with Moran Healthcare, which some people will remember. And the nursing homes had 4 or 6 people to a room. So we've come so far from there. We have to recognise the advances we've made. We now have people only in their own room, which can be lonely, but can also be safer. So we have to balance that. I went to an influenza outbreak about 15 years ago on a Friday night around midnight. And I came into a room with 6 men and I said, why is that man so red in the face? What's his temperature? Oh, I don't know. So I said, could you take it, please? He had a temperature of 39 degrees. He had influenza and he died a few days later. The man next to him was under a sheet, shivering. I said, what's his temperature? Because that's the simplest thing you can take, you know.
Yeah.
If, you know, mothers know how to take temperatures, fathers should know, and many do. And he had a temperature of 38.5. I think he survived. But another lady in the nursing home also died, several died, and that was from influenza. So it's deadly. And when you go into places where people have minimal care, and I said, well, why wasn't the temperature taken? Oh, one of our patients had absconded. So the issues are really complex and difficult, but a lot of it just comes down to staffing and to intelligence, assessing the situation. What could we do better? What could we do more? Could we get more in the way of voluntary people like relatives? What else can we do? You know, what better training can we have? How can we motivate our people to say, these are precious. These are the repositories of wisdom. These people need to be listened to. Anyway, so there you go.
No, and there's so much of what you've just said that resonates. I mean, you know, obviously, Robert, we saw last week the Nursing and Midwife Union. We saw strikes across the country, and you know, my understanding of one of the key triggers of that movement is that they are advocating for a carer to patient ratio. You know, they're advocating for a minimum of 1 to 4. I think what was really interesting, I didn't know until quite recently actually, that if as a registered nurse, if you choose to work in the aged care sector, you're actually paid less than you would be paid if you were in the normal healthcare sector. And I mean, I guess I don't expect you to have an answer for me on this, but how could there be logic in that? Why is it that a nurse working in an aged care setting should be paid less than a nurse working in a hospital setting, do you think?
There is impression that less skill is required, and largely a false impression. You know, when I trained as a junior doctor, I came out of medical school 35 years ago, I think. The key people I turned to were, of course, the consultants I was working for, but also the nurses. And I got teaching in neonatology, that's newborn babies, in intensive care, in emergency care. You know, I just went to the head nurse and I said, what do you think? And she would, back then it was almost always women, but some men. And, you know, they would say to me, you know, this or that. And you learn from experience, whether you're a nurse or a doctor or a physio, you've got tremendous experience. We should be making use of that practical experience to teach younger people. And people have to swallow their pride and listen to alternate professionals to understand their expertise and what they can teach you. I think nurses, it's simplistic to say pay them more, but you know, I guess what you can do is also look at the organisation, and that I don't have all the answers, but in public health we look to how we look after people as a group as well as an individual, and both are important, and I don't have anything profound to say there.
So having had 5 months now to kind of get around and talk to people across the community, one of the key policy areas that, you know, has consolidated for me, and you would have heard this on Sunday, is the concept of healthy communities and healthy families and healthy systems supporting communities and families. I know that what the sense I get is that there was once upon a time an awful lot of good work being done in public health in terms of the federal government providing a level of coordination across services. There was once a national, and actually I'm interested, you talk about the Immunization Coalition from 2018 to 2020. Does that coalition still exist, Robert, or?
No, I'm very happy to talk about that. I was the chairperson. I've been on the board for over 10 years, honorary position, and I actually chair the scientific board, so I organise 2 conferences a year, and the second one is always about adult and elderly medicine and preventative immunisation. So I've been involved in that area for a very long time. It is known for the last 5 years as the Immunization Coalition because we cover all of the potential vaccine preventable diseases for the very young, adults, elderly. It used to be called the Influenza Specialist Group, boring detail, and we realised that there was so much more we could offer than not just promoting influenza immunisation, even though I did on Channel 9 last night. The Immunisation Coalition is very close to my heart. It's something that I do because it's meaningful. We're constantly working to promote better public health. And it's not only immunisation. We look at the drugs that people can use and the measures, be they, the simple things that GPs do, like prescribe rest and exercise and good diet. We're not primarily about that, but we are in favour of that. So it's a marvellous organisation that's got a very good website that people could spend 5 minutes looking at, Immunization Coalition. And yeah, what else would you like to know?
No, well, it's just what I'm interested in is that if an organisation like that exists, how much of a voice does that organisation have when it comes to access to federal policy? Is that a voice that is listened to when these discussions are coming up?
Good question, and we're running our 4th or 5th round table in the last 6 months with industry, the professional organisations like the Pharmacy Guild, and government. And we've got people along to these round tables. We've got one due again next week. We also work with all of the industry people. We also work with the representatives of industry like Medicines Australia. We're working with them on the moment on promoting the value of vaccination. Australia is, in one sense, the worst in the first world. We discount the value of vaccination every year by 5%. Every other country does it between 1.5% and 3%. What does discount mean? We say, oh, well, you may not live another 10 or 20 years. And so we discount the potential benefit of vaccination in saving lives or preventing disability. But we do it at a rate which is twice or more other countries. So we devalue vaccination for children. We devalue vaccination for older people as well. And we're working with Medicines Australia, and I read a document only yesterday about this. I've worked with GSK, I've worked with Sanofi Pasteur, anyone in the field we work with. We're working with the pharmacists and the representatives of GPs and specialists. So we're trying to, as a group, promote the public health, largely on a pro bono basis, but we do have to pay for our staff. You know about that. You've got to pay for your staff. And we have a handful of people who do a fantastic job. And as I said, take a look if you want to spend 5 minutes to see the breadth of the work we're doing.
Fantastic. So a couple of other things that had been raised with me along the way is that there are various reviews that have been done and reports that have been developed, in the course of the last 3 to 6 years. And for whatever reason, those reports and strategies have been stuck. They've just been lost within the federal government system. So, for me, there are 2 specific things that I will be calling for and advocating for the people of North Sydney, and not because it's what the people of North Sydney want. So the first is I believe there's a national preventative health strategy that has been written, that is ready to roll, and it is just stuck. It's gone missing in somebody's top drawer. So, and my understanding is that the role of immunisation across our community is very definitely part of that strategy. So, I'll be advocating that strategy be pulled out of whatever folder it's in and resourced appropriately. The other thing, though, is that I will be advocating for the establishment of a National Centre for Disease Control and Prevention, because we don't have one here in Australia, correct?
I know that. Who has been advising you on that before I say anything?
Well, it's just people like you from across, the infectious diseases specialty, and so I'd be interested in your opinions on it, and true opinions.
There are a bunch of strongly opinionated people, and that includes me, and so I think it's wise to take counsel from a group of people, not just one. People can come across as very plausible, but you need to scratch the surface pretty hard before you see what's really going on. So being diplomatic, I think COVID has shown us that experts are coming out of the woodwork left, right and centre, and their expertise isn't as good as they purport. There are a lot of TV commentators who don't actually have experience in infectious disease epidemiology. They just have a dose of common sense and a related field expertise. So I'm not going to name names. I'm just going to say, take your counsel carefully and wide-based, and don't just trust me or anyone. Trust a group of people where you get a consensus. There's a lot of people who are pitching for such a national body to be, especially in Sydney or especially in Melbourne. And we've got to get away from that parochialism. We have to get to a point where people in each state are listening to each other really well and actually have the expertise. And you can sometimes judge an expert by the common sense that comes out of their mouth or not, as the case may be. So I think having a national board is a great plan, a great objective, but you've got to do it right. And it's not about putting people in, oh, now I'm the president and I'm now the chairperson and I'm this. It's about getting people who are totally committed to the public health, who aren't there for the prestige or for the money or for whatever else is driving them. They're there for the public health. If you combine that with going for a national centre for public health, that would be great. But it's got to be, it's got to be like 100 years ago when you talked about the states coming together and putting together in your speech, you talked about putting together a, what's that term?
A constitution? A constitution.
And we didn't have Labor Party or Liberal Party back then. We just had people who wanted to do the right thing. And so many did. And I think just like that, we should have a public health authority which is well staffed, well funded, and is highly collaborative.
Well, so what I will do is just picking up on that point you've just made about well-staffed, well-funded and highly collaborative. They're definitely the three key pillars behind anything that I've spoken about with anyone, because I think the conversations that I've had is there's a real sense that a number of years ago we had a strong alliance across the states, and that included the federal government, where they were keyed up to share information cross-border, to learn from each other, to leverage really quickly. But unfortunately, that in the last 6 years, that network had been deconstructed by the current government, and the suggestion was that it needs to be re-established, and that to call it, we can call it whatever we want to call it, but that the name that had been suggested was this National Centre for Prevention, National Centre for Disease, and Prevention.
Control and
yes, thank you.
Communicable Disease Centre, the Centre for Communicable Disease Control and Prevention is what the US call it. I agree with you that there's been a drop in investment. We used to have Medicare locals. I went around Australia giving lectures for GPs and others and nurses, and having major Q&A sessions. I went all around Australia twice. And then the money was taken away by the current federal government some 5 or 6 years ago. So I'm completely understanding of the disinvestment that's gone on. And I support your approach to innovation and revitalisation. I think that would be just fantastic. I'm trying to think of another thing, but I've lost it. Over to you.
Well, no, I just think so. To be kind of, my sense of the best role okay. So my sense of our community is that we are best served when all levels of government are actually able to work together really efficiently and effectively. You know, local works with state, and then local and state work with federal, and vice versa. Federal works with state and federal works with local. And I think if there is one kind of consistent message I've heard in the last 5 months, is that there's been a real fracturing of that process across our country. From my perspective, and I mean, I guess what I'd be interested to hear from you is what you think is the best role for federal government when it comes to public health, because you know I have some opinions which I'm happy to share, but I'd like to hear yours first. So as you sit in your role, you know, as an incredibly experienced clinician who still has day-to-day access, what do you think the role of the federal government is in providing better public health for our country and our community?
Yeah, well, certainly a need for more consultation. It looks curious that we have hospitals under the states, and they tend to work quite well, yet we have aged care and GPs under federal. Certainly aged care perhaps might be better dealt with more locally. And it's just a mess. Whatever you do could only be better.
Yeah.
I did have a thought before that you have bitten off a lot, and you know, choose your top 4 or 5 and give your energy to them before you burn yourself out. I think health is important. I think elderly people are really important. I think nurses are important. I think application of the findings of all of those, there must have been nearly 20 reviews and commissions into aged care in the last 21 years. At least I've read that. So just getting the consensus across those and saying, okay, what are the things that everyone's saying? Let's do that first. And what are the things that are both urgent and important? Let's do that next. You know, I'm not a public health specialist in the sense of policy. I'm pretty narrow in the way I'm an infectious disease person and can talk about that. But I don't pretend to be an expert on policy, health policy more generally. So I'll stop there.
Well, thank you. I mean, I guess from my perspective, and it is reflecting on what I've just heard from you as well, you know, I've worked around that health promotion and public health space for 30 odd years in different roles. And where I feel I'm settling, and where I believe the North Sydney community is asking me to settle, is that, you know, really the role for federal government in this is a role that's about leadership. So actually being able to put aside ego and kind of say, no, this needs to be based on science, evidence, you know, let's lead our country forward. I think it needs to be the best role for federal government to play is coordination. So I think it is about enabling, because, you know, and we've seen it when we've had a pandemic ripping through our country. I think one of the sad things is I had never thought of myself as a New South Welshman really until the last 2 years, where I've been forced to say I'm a New South Welshman because I couldn't go into Queensland or Victoria or anywhere else, you know. So I think coordination at that federal level is really important. And then I think where it's required, funding and coordination of access to things like vaccines and, you know, rapid antigen tests, and where it makes sense to have one body managing that as opposed to 7, you know, separate and disparate bodies. I think that comes back to leadership and coordination. So and I do think
that's far better than I could. Go on.
Well, you know, I've had the benefit of lots of conversations with people like you know, and my conversation with you today is I just always am so grateful, because I feel like I learn something a little bit more each time I speak to someone. So I am mindful of time, and I try to tell people that I promise the conversation will happen and be done by the time, you know, we've had our cup of tea. So I've finished my cup of coffee, and I'm sure people's tea is going cold. But I do just want to thank you for taking the time to speak to me this morning. Just to reiterate, what I've really heard from you is that when it comes to how we are addressing the needs of our aged care sector, there are many solutions that are yet to be explored by our community. Some of those may involve looking at upskilling personal relatives of people who are currently in aged care facilities, training them, skilling them up, enabling them to get in there and actually be hands-on. It is looking at the workforce that is currently involved in aged care and around, disease prevention, and actually fundamentally being open to learning as we go and adapting, rather than kind of what we tend to have seen in the last 2 years, which is we have one strategy, and that strategy is let's shut down. Let's lock everybody out. Let's put people in isolation. For people who are older, you don't want to spend that time by yourself in a room in solitary confinement. So I really, really appreciate you sharing that information with me. Also, I think I'm definitely going to go online and check out the Immunization Coalition. And I think, it would be beholden on all of us that are on the call today, if you're interested in seeing what is, the potential for us as a country and how that's done and how it can be done better. I think that's going to be a great resource. And then I think, the final thing is just to be aware that there are people across the community with extraordinary expertise. And the simplest way for us to leverage that expertise is to provide opportunities for those people, so people such as yourself, to get out there and talk to other healthcare professionals, to enable a general upskilling across the community, so that we're not segregated, we're actually joined around these challenges as they face us. Because, if there's one thing that is certainly true, it's that COVID is not going anywhere. We do have treatments for it, but we don't have a cure for it. So we really, while we might be coming out of this Omicron wave, the reality is there'll be another wave in the next, 6 to 12 months. So let's be prepared for it by embracing the learnings we've been able to, pull together in this last 2 waves, and try and do things a little bit differently going forward. Because I don't know about you, Robert, but my grandmother used to always say the definition of insanity is doing the same thing in the same way and expecting a different outcome. And I think, generally as a country, we can be united in a belief that we haven't handled aged care well in the past 2 years. As someone who's had family members in aged care and seen what that did to them, it is heartbreaking. And I think if we can take a moment now and make sure that when it hits again, we're doing it differently and better because of the observations of people like yourself, that's got to be a good thing for our country.
And if I could give a plug, I will every day, but if I can give me a plug, there's a free website that teaches 14 and 15-year-olds about science and immunisation called Omega, not Omicron, Omega. omega.org.au, and there's 10 lessons directed at 14, 15-year-olds in science and biology through immunisation, with lots of videos. And if people want to learn about the science of immunisation, I do actually do things that pertain to children as well as the elderly.
Well, I think that sounds fantastic. And to your point, what age group did you say it actually targets?
So it's year 9 and year 10 at high school. And it's called omega.org.au, and it's free.
Fabulous. Well, and I've got to say, you might have created it for year 9 and year 10, but I'm pretty sure all of us would learn something from it, so, which is fantastic. Well, Professor Robert Booy, thank you for joining me this morning. I really, really appreciate it. And to everyone that's been watching today, as always, you can go back and listen to this again. If that's something you like to do. I feel like Robert shared a lot of information with us today that's really, really important. So this will be up on YouTube in the next little bit. And Robert, just thank you so much for your time.
Good to talk.
And I look forward to speaking, and for your support. It's very much appreciated.
You're welcome. Cheers.
Okay. See you. Have a nice day. See you guys. Bye.
Authorised by Kylea Tink, North Sydney, New South Wales.